welcome back. Physicists, I'll have to admit, often consider patients as sort of a spherical body of water. Well, that's not quite true. And we have to consider some of the effects that happen in patients to get a realistic dose distribution. So I'm going to talk about some of that in this video. I'm going to talk about the effects of inhomogeneities, let's say dose in a lung versus dose in a muscle. Those are quite different. I'm going to talk about the effects that happen near the skin of the patient. It's a sort of a special region where the physics can get a little bit complicated and important to understand. And then we'll move on in the next videos to back to topics of planning. Here we go. So I'm going to start with the topic of superficial dose and dose to the skin of a patient. So we need to consider what is skin. So we think of this as the basal layer of cells. These are growing cells, and so they are therefore sensitive to radiation. Of course, there's other things in this layer, vasculature and so on. This layer is 0.05 to 0.4 millimeters deep. For the physics point of view, we usually use 0.1 millimeters as a reference depth for physics measurements. If you measure at that point, that's considered a skin point. The ICRU, International Commission on Radiation Units, Report 38, they recommend the specific number of 0.07 millimeters for the depth of the skin. We already talked about the physics of how dose is deposited in this superficial skin layer. That was one of the topics of the last video, video 10.1, so you can go look at that. But you'll remember this picture, and what you see here is that the dose is deposited by electrons, of course, in the very superficial layer right at the surface. Most of the photons have not interacted yet, and there aren't many electrons. The dose is very low. As you go deeper, you get more electrons contributing, and you get this buildup effect, and eventually the dose reaches a point of D max. And so here's what a curve might look like. This is data adapted from this reference where they made very sophisticated measurements of the dose near the surface. And then what you'll see is there's this skin sparing effect. So in other words, skin sparing, the dose is low, relatively low near the surface. The skin is spared. But you have to say it's not zero, right? There is some finite dose there. So where is this dose coming from if the photons haven't interacted yet in this 0.1 millimeter layer? So to understand that, we go back and look at the head of the linac. Here's the image. This was from video 9.1. And what we saw was that the electrons interacted in the target, and that made photons. And then those photons went through the collimation assembly system, and they interacted there. So they scattered off the primary collimator, they went through the flattening filter, they scattered there. In the process of doing that, what happens is electrons are created. Some of those electrons will go down and reach the patient. And so those are largely what contribute to the skin dose, the dose at these very superficial layers in the patient. The skin dose can create some pretty negative reactions in patients if it's not understood and managed right, as shown here. So with that as background, I'm ready to go and talk a little bit more about the skin sparing effect. It's going to have several dependencies, and we're going to go over those. So it's going to depend on the field size and the energy of the beam, of the megavoltage photon beam. It's going to depend on what devices are in the beam. And it's also going to depend on the angle of the beam relative to the patient. So I'm going to go over each of these one by one. So first of all, let's look at field size. So here I'm showing the percent depth dose curve for a 6 MV beam, again adapted from that reference I showed you. And what you'll see here is a 10 by 10 field, and then up on the top a 40 by 40 field. And so you'll see immediately that the dose to the skin is lower in the 10 by 10 field and higher in the 40 by 40 field. And that you can understand because of what I showed you before. Remember, in the head of the linac, there's this whole collimation system where electrons are created. And when you have larger field sizes, more of those contaminating electrons are made, giving you a higher superficial dose. And you'll see that it can jump substantially by more than a factor of 2 when you change the field size here. The next topic on our list is to look at the dependency on the energy of the beam. So here I'm showing 2 PDDs, 6 MV and one for 18 MVs. And what you'll see is that the PDDs are quite different in this superficial region, but right near the skin, they're actually pretty similar. And there's a field size and energy dependence to this as well. So that's what I'm showing from this reference. So here you'll see that as the field size increases, the surface dose increases as well. And we already saw that before when we talked about field size. But then this is also showing the energy dependence. So you have green, high energy beams, and red, the low energy beams. And you'll see that they're actually very similar, and it's hard to say that one is hugely different than the other. This is data from many different machines. So this is in contrast to the sort of lore around this, which says that the skin dose from a high energy beam is lower than the skin dose from a low energy beam. And that's sort of become kind of a statement that people remember, but it's actually not really the case. And if there is an effect, it's very slight. So next on our list is to look at what happens when devices are put into the beam. An important reference for this is going to be the AAPM task group number 171. This looks at the dosimetric effects from couch tops and immobilization devices, but it actually talks about a lot more than that and has some general physics behind what happens when you put devices in a beam. So let's look at this. One type of device that can be in the beam is the patient support assembly, or the so-called couch. You'll see here sitting under the patient. Of course, if there's a beam from the side, it's not going to matter. But if a beam comes in from below here, let's say, then that device is going to contribute and have some effect to the dosimetry of that beam. There's actually 2 effects. One is that it attenuates the dose. It absorbs dose deeper in the patient. So like in the middle at isocenter, the dose is going to be lower by a few percent, depending on the exact specifics. But it also will increase the dose on the skin. Let's look at what this looks like in terms of PDDs. So here's the depth dose curve for an open field. I'm going to show the open fields in blue, so nothing in the beam. And red here is now with the couch in the beam. And you'll see that the skin dose is very much higher with this device in the beam. Of course, the exact magnitude of this depends on exactly what type of couch you're using and so on. There's many different models, but you can see it can be a very large effect. Now, this will also have an energy dependence. And so here I'm going to show everything all together, the 6 MV beams and the 18 MV beams in the dashed lines. And you'll see that this effect has an energy dependence to it. And if you look at just the beams that are going through the couch, ones in red, you'll see that the effect is bigger with 6 MV. So that is maybe reflected in this lore that the surface dose is lower for higher energy beams. And that certainly is true when you have a device in the beam like this. Other types of devices you can have in the beam are immobilization devices to hold the patient in place, reproduce the position. And one example of this is the thermoplastic mask shown here. The mask keeps the patient in place, but it also acts to increase the skin dose. Here's some data that shows an interesting effect on this, that the thermoplastic masks can actually be stretched by different amounts, because they're molded in place where the patient, they're put in a warm bath and then they're stretched to the patient. So you can stretch them by different amounts. And so here what you're seeing is that you'll see data with no mask, and then what happens when it's unstretched or stretched by different amounts. And basically, yeah, the more you stretch it, the thinner it is and the less the contribution is to the surface dose. But in any case, it can substantially contribute, again, depending on the thickness and the stretching. Here's another immobilization device that's used to hold the patient in place. There are many different varieties of these. This one particular one is the VacLock bag, and it's sort of a plastic kind of poly sheet with beads inside of it. And these will also increase the dose. If you go through this bag, if you look at the values in TG175, the increase in a 6 MV beam can be anywhere from 10% to 50% or even more, depending on the field size and the thickness of the bags. Another device you might sometimes see in the beam would be a lucite tray, a plastic tray. That might be put in here under the head, maybe to hold blocks, for example. If that tray is in there, that's going to contribute dose to the surface as well by the similar effects that we've just been talking about. Again, electrons produced from the device that then reach the patient. And that effect can be large, like the other effects that we've been talking about. It depends where that device is positioned. If it's closer to the patient, the dose is going to be quite a bit higher. So far I've been talking about skin dose as if it were a bad thing, but sometimes you want to increase the dose to skin for various reasons. Maybe you're treating a surgical scar or some other superficial disease, and so you want to boost the dose there. And in that case, you use what physicists call bolus. Here's a picture of some bolus. It's tissue equivalent material, sort of a flabby plastic type substance. That's one version that you could use, or you could use paraffin wax. There are other options. In this type of bolus, you put it over the patient's skin, and that boosts the dose to the skin. You can buy different thicknesses of this bolus material. Now let's look at what this looks like in the planning system. Here's a single 6 MV beam coming perpendicular to the skin with nothing in the beam, no bolus. I'm going to draw a line here, and you can see the depth of this curve on the right, and this is delivering some dose here at this point. And you'll see the skin dose is relatively low. Now, if I make a same plan, but now I add some bolus here, which is in the planning system. So I put 5 millimeters of bolus here. And you'll see that the skin dose is much higher. Even though the prescription dose here is the same at this point, the skin dose is much higher in the plan with the bolus. So that's the boosting of the dose to the skin. So there you have it. Those are some of the basic effects that can happen in some of these more unusual regions inside a patient. I'm going to leave you with a little bit more reference material here. These effects are fairly subtle. There's other things going on, but for now I'm going to leave it there. Thank you.